Welcome back to Africa Health Week, the final session after 3 wonderful days. It's the closing Tech Talk session, and to present it is Saul Kornik. He's going to be speaking about escalating private healthcare costs, and Saul is the CEO and co-founder at HealthForce. He'll be joining us after his presentation for a Q&A, so get your questions in the Q&A box. Here's Saul now.
Hello everyone, thank you to Africa Health Week for having me here today. My name is Saul Kornik. I'm the CEO and co-founder of HealthForce, a company working in primary care and digital health, particularly telemedicine in South Africa. Today I'm going to be talking about escalating private healthcare costs and also talking about some of the innovative solutions to addressing them that we see happening, particularly through technology. The two things I'm covering today, as I mentioned, the escalating private healthcare costs, but also the opportunity for innovation. Starting with then the escalating private healthcare costs. There are 3 parties to the healthcare system that one needs to keep in mind when looking at healthcare. There is the demand side of the healthcare system created by patients who need healthcare. There is the supply side of healthcare created by the providers of healthcare. And then there's this weird third-party player in healthcare, the funders of healthcare, who pay on behalf of the patients to the providers for the patients to get access to care. I'm going to look at each of these 3 pieces and how they contribute towards the escalating private healthcare costs. So let's start with the funders, these third-party payers. In South Africa, using this as an example, there are around 57 million people. Of these, only 16%, or around 9 million, have access to medical scheme cover. The average price for medical scheme cover for a family for a month is around 3,700, 3,800 Rand. This is a little bit outdated, so it might be more expensive than this at the moment. If one compares this monthly medical scheme premium for a family to household income in South Africa, one sees that the vast majority of South Africans earn less than 6,250 Rand per month. That's 3/4 of the population, which makes the scheme cover completely unaffordable to them. In fact, the only category of household income here that could even think about paying for medical scheme cover is this category over here, those people earning as a household more than 12,500 Rand a month. But even here, if we take the lowest category of 12,500 to 25,000 Rand per month, and we take a look at the middle family earning income here of 18,750 Rand, you can see that this monthly medical scheme premium is 20% of household disposable income. That's a massive share of income to pay for something that you're not even sure you're going to need in any given month. So why is this so unaffordable? What we've seen over the last decade, and even more so since the advent of COVID, is that there's been a real decline in medical scheme membership in South Africa. And what I mean by that is that the proportion of population belonging to a medical scheme has declined. And in real terms, for the first time over the last year, absolute numbers of medical scheme members has declined. Now, medical scheme administrators who make money out of the medical scheme premiums collected on behalf of their non-profit pools of funds are needing to cover their costs. And what we've seen since 1990, since the end of apartheid in South Africa, when there was this massive burgeoning of private healthcare to cater for wealthy white South Africans who were scared their healthcare was going to get taken away by a new regime, we can see here that as people moved into private scheme coverage, there was an escalation both in administration costs as well as in non-healthcare costs. In other words, these costs over here are more than just administering the collection of premiums and the payment of claims from the scheme. They're about adding additional value adds to the medical scheme, such as pharmacy benefit management, that allows the administrator to generate additional income by creating value for medical scheme members. But this has created an escalation in costs and has made medical scheme coverage increasingly more expensive. However, there are another two large reasons why medical scheme premiums have had to go up so much over the last 2 decades in South Africa. The first reason is fee-for-service. What I mean by this is we live in a healthcare system where a healthcare worker only receives a fee when they deliver a service. In any system, when someone is paid only when they deliver work, they will try and deliver as much work as possible in order to make a living. And this is no different in healthcare. In order for a doctor to make a living, they need to deliver services to earn a fee. However, the incentive in the system is misaligned with keeping a patient healthy, where doctors and other healthcare workers over-deliver services in order to generate reasonably income for themselves while over-servicing the patient and often doing unnecessary things to help them. This increases the cost of access to healthcare. At the same time, funnily enough, it reduces health outcomes because healthcare is not a normal good. Healthcare is one of these strange markets. It's not really a market. One of these strange markets where at a system level, the more you pay, the less you get. The classic example of this is giving birth for a woman. In a system where a midwife looks after a mother giving birth, that mother has a 20% chance of cesarean section. However, where that soon-to-be mother goes to an obstetrician for care, that cesarean section rate goes up to 80%. A cesarean section is a serious surgery with complications, potential complications for mother and child. And at the same time, as a service delivered by an obstetrician, is much more expensive. Now, it's not the obstetrician's fault. This is the way the obstetrician generates a revenue. In addition, this is what the obstetrician is trained to do. The second reason why there's been a massive escalation in healthcare costs in the private sector is due to people moving to hospital plans. In South Africa, the regulations say that there are prescribed minimum benefits, PMBs, that every medical scheme needs to offer its members as an absolute minimum in terms of healthcare service. PMBs are largely delivered in the hospital setting. This means that as people become less wealthy in South Africa, as medical scheme coverage of more comprehensive plans becomes more and more unaffordable, so people are dropping down to the cheaper hospital plans. However, the flip side of this means that people are either waiting till quite late when they're very sick to get access to healthcare, because they know that when they're that sick and they go to hospital, at least their medical scheme will pay for them. Or alternatively, they're seeking care in hospitals and with specialists unnecessarily. Again, if you go to a specialist for access to care, it is much more expensive, and at the same time, it is often delivering much worse health outcomes. As people drop to hospital plans, people's benefits in the medical scheme become much poorer in terms of day-to-day benefits, which means they have less and less access to the lower cost and kind of preventative care that you get from primary care providers such as nurses and GPs. So the combination of fee-for-service and people dropping to hospital plans is pushing people to get more healthcare from much higher level specialists, much more expensive specialists than they need to get. Let's move now to the demand side of the healthcare equation, the demand for healthcare by patients. This is the distribution of population in South Africa by age group. If one considers that the young people and the old people of South Africa are generally outside of the working age, that only leaves 56% of the population to work. And of that 56%, the unemployment rate sits somewhere at 34%, depending on how you measure it. That leaves a very small percentage of the population who are earning money and who can afford to pay for healthcare on behalf of themselves and their families. It's no surprise then that the vast majority of people in South Africa need to get access to state services which are free because they simply cannot afford to pay for that healthcare out of their own pockets. And it's also then not surprising that a very small percentage of the population supporting their families with a higher level of income can actually afford medical scheme coverage, more costly private care services that are paid for by medical schemes. At the same time, the burden of disease in South Africa is quite different to the rest of the world. Patients in South Africa look nothing like Sweden, where, as you can see here, the blue lines are non-communicable diseases. If one takes a look at a market like Brazil, which is also considered to be one of the BRICS countries, one of the developing world up-and-coming countries, we can see even here, there are only 2 non-communicable diseases in their top 15 diseases in terms of disease burden. South Africa looks quite different. South Africa still has the majority of its diseases in its top disease burden being infectious diseases. There's something called the epidemiological transition, where a population moves from being mainly suffering from communicable diseases, infectious diseases, to non-communicable diseases or diseases of lifestyle. And that happens as society becomes wealthier across the board. In South Africa, we're very, very early in that transition, which means our disease burden is actually very high because we still have non-communicable diseases while our infectious diseases are even worse. So now we understand the patients. Let's take a look at the providers of healthcare, the supply side. This is the number of beds in South Africa since 1976. What you can see is that around 1990, there was a proliferation of hospitals building private beds, private hospitals with private beds. This happened after 1990 as an unregulated private healthcare sector burgeoned on the back of the fear of what a new regime would do to existing and high-quality public healthcare services. Where it is today is that 83% of the beds in South Africa are delivered, care in those beds is delivered by 3 listed companies in South Africa, each generating significant profits every year. This investment in hospitals has created the skewed system that also allows hospital plans to push patients into hospitals. And if one takes a look at medical scheme spend into those hospitals, you can see it occupies the vast majority of healthcare spend paid out by medical schemes. Let's take a look at specialists specifically. This is the number of acute hospital beds in South Africa. 3/4 of those beds are in public sector and about 1/4 is in private sector. Yet this 17 billion rand of specialists in private sector constitutes well over half of the country's specialists, serving just 1/4 of those beds. Private sector has a disproportionate number of specialists. Looking at overall healthcare spend in South Africa, one can see that the public sector spending in excess of 160 billion rand per annum and private sector spending in excess of 160 billion rand per annum are each 50% of the healthcare spend in the country. Yet this 50% of the healthcare spend is spent on just 16% of the population. And hopefully now you have a better understanding of why. It's a similar story in other African countries. There's single-digit health insurance coverage in every other African country. South Africa is actually the only country in sub-Saharan Africa that has double-digit insurance coverage at 16%. At the same time, Africa has the youngest and fastest growing population on the planet. Population in sub-Saharan Africa is expected to double, more than double, in the next 30 years. Africa has not gone through that epidemiological transition to diseases of lifestyle. In fact, by some measures, Africa has the highest disease burden of any region in the world, with 25% of the global disease burden. Mapped out like this map shows the size of the country in relation to the disease burden of that country. And you can see here that Africa is a very swollen continent, while continents like Europe and America and parts of Eurasia are almost non-existent on the map. Their disease burdens are so small in relation to India and Africa. At the same time, the distribution of physicians around the world is completely the opposite. This map here shows the number of physicians per country. Here you can see a very swollen America, a swollen Europe, and a swollen China. Yet Africa is almost non-existent. Because the reality is that with 25% of the global disease burden, we only have 2% of the world's physicians. So, hopefully you've got a better sense of why private healthcare costs are escalating in Africa, and in South Africa more specifically. What are the opportunities for innovation here? The only way to make quality healthcare affordable and accessible, this triad, this iron triangle of quality, affordability, and accessibility, is really what every healthcare system is trying to achieve. The only way to make that happen is to enable clinicians to work together in teams and to organize those teams around the patient. In other words, in a patient-centric manner. What does this mean? This means that, first of all, one needs to take a look at the level of complexity of the health issues of a population. And one finds that even when sick, most people in a given population are actually healthy. A young 25-year-old, even with COVID, is still a healthy person with low risk of complications. There are very few people in any given population who have very complex conditions, who are very sick, who have so many comorbidities that even getting the flu can result in them needing much more complex level of care. This triangle is very, really important to recognize again that most people are healthy even when they're sick. And the objective of a healthcare system organized in teams is to allocate the appropriate team member to the level of complexity of the patient. So if one looks at resource intensity, a mostly healthy person, even when they're sick, may just need a single person like a nurse to help them, to look after them, or maybe a nurse and a GP. Whereas on the other end of the spectrum, the few people who are very sick will need a full team of healthcare workers, probably in a hospital, in an ICU, to look after them. By matching the team member to the need of the patient, one reduces the cost, improves the quality. Remember what I said earlier about primary care can often deliver better health outcomes than going straight to a specialist. And of course, it improves accessibility because the single resources, nurses and GPs, are more available and more accessible than hospital beds and super specialists. Healthcare ultimately needs to deliver care in one value chain, from primary care, which is nurses, GPs, pharmacists, psychologists, and even pathology, through to community care and out of hospital specialists, eventually into hospitals, through the specialists that I've got in this diagram here. And what needs to happen is that if there are clinicians working together in teams across the whole value chain, people need to get referred across this value chain based on the complexity of their need. In other words, a very complex person may end up over here, not a complex person, but a person with a complex condition may end up in a super specialist hospital. But once they've had that hospital care, they can often be maintained with a single resource, a nurse or maybe a GP, back at home or in their local community. Now, by way of an example, Health Force has developed a clinic product that sets up the nurses in pharmacy clinics to call a GP through remote telemedicine. And we're about to launch a new app that will allow patients to access that nurse and, if necessary, a GP and a psychologist on their phones at home. What this means is that by making nurses and GPs as a team available to the vast majority of the population who are healthy, we can capture them at the side of the pyramid and funnel them through to the more resource-intensive layers of the system as their need requires, as long as we're organizing those skills as a team around the need of the patient. Again, reducing the costs, increasing access, and improving quality. Health Force has been going for just over 3 years now. We're in over 450 clinic rooms across South Africa. We have over 500 nurse users, and we've done over 1 million patient consultations with those nurses. At the same time, we've delivered over 110,000 telemedicine consultations into those nurse-run clinics. And the average wait time without a booking to see our doctors on the telemedicine service is 1 minute, or at least it's been 1 minute for the last few months. After every consultation, patients rate our doctors, and the average rating of our doctors by patients is 4.95 out of 5. This is a classic example of how we're bringing low-cost GPs, and more importantly, setting up nurses as the lowest cost entry point into the healthcare system through the use of technology. Opportunity can be seen in terms of current trends as well. This opportunity of lowering cost of care and improving quality and accessibility by organizing teams of healthcare workers around the need of the patient. First of all, in the post-COVID world, we're seeing people drop off schemes, which, as you've seen, are more expensive, to looking for lower cost primary care insurance or moving into uninsured markets. This naturally sets up a situation where people can invest in delivering primary care services because more people want to get those primary care services. At the same time, fewer people then can afford hospital care, and they are seeking care in lower cost settings or through virtual care services. Essentially, what I'm talking about is something called value-based care, without having actually mentioned it. And value-based care is all about looking after patients and keeping them healthy with a team of healthcare workers, rather than treating them on a fee-for-service basis when they get sick. And our market in South Africa and across the continent is primed for value-based care. Why? Because as you've seen, our critical mass of disease burden is high. We've got a critical mass there. That means that there's a huge opportunity to deliver care across the spectrum. At the same time, we've got a lot of compressible costs. We've got a lot of specialists and highly trained people helping people who should be dealt with in a lower cost primary care setting for better health outcomes. At the same time, there's an opportunity to translate a lot of the infrastructure we've got at the moment into high value sites of care, using technology to make more specialized skills available in things like pharmacies and nurse-led clinics, which previously was unavailable, setting those clinics up to be higher value points of care. And then, of course, there's this model moving to beyond the hospital, looking at setting up networks of diverse care delivery settings, such as pharmacies and nurse-run clinics and community health centers. Systems where you can capture a high market share and generate more profits and more growth in profits than if you sit in the existing high-cost hospital and private medical scheme market. And then finally, the highest value is delivered to the lowest economic quartiles from a business perspective. And that is simply because the focus up until now has been on delivering care to the wealthiest people in society, which means that as a business, if you want to generate more returns on your investment, the lowest economic quartiles are the people to try and serve. So from a business perspective, it makes sense to target creating teams to deliver high quality care in a preventative and early stage setting than it is to invest in specialized and complex care, which aligns with, as it turns out, better healthcare delivery to populations. As a last thing, I just want to mention how COVID has resulted in the rapid adoption of telehealth services. This was a US study. From a consumer perspective in the US, people moved from 11% using telehealth to 46% using telehealth after COVID, with 76%, three-quarters of the population, interested in using telehealth going forward. That's a massive leap from 11%. There's also been massive adoption from the provider side. In fact, 50 to 175 times the number of telehealth visits have been delivered post-COVID compared to pre-COVID, and 64% more providers in the US are comfortable using telehealth services. In fact, in the US, they estimate that the market will grow from 250 billion to 1.25 billion rand, out of hospital spend could potentially be virtualized, up from 3 billion rand. Dollars, I must say. So how do we eat this elephant? Because this is a massive thing to try and deliver a solution that looks like this. Or for vegetarians, how do we eat the artichoke? And the answer is always one bite at a time. The solution in healthcare is always to deliver something of functional value right from the outset. If one considers it and makes it, draws the comparison to building a car, what you don't want to do in healthcare is first build the wheel and then the chassis and then the mod cons on top of that. You don't just want to deliver something that's functional. You ultimately want to help the patient get from A to B, whether that means first building a bicycle and then a scooter, working your way up to an airplane. That's the approach you've got to take. When you deliver something across these levels that ultimately delivers something of functional value into the healthcare system, rather than delivering a small piece that's not functional and will have no impact. This is because there's no such thing as an MVP in healthcare. This was something coined by a big investor, tech investor in the US, who does a lot of investment into healthcare. And the reason there's no such thing as a minimum viable product in healthcare is because the incumbents in the market occupy and have captured the whole value chain in the delivery of healthcare. And if you want to offer something into that healthcare space, you have to offer something that's a significant portion of that value chain in order to be able to capture the market in that particular piece of the patient's process through receiving healthcare. And so ultimately, again, one wants to deliver something of value in order to capture something within that value chain and then build out from there. And so the solution to something like building a healthcare system which has teams of healthcare workers focused around the need of the patient, delivering care at an early stage at lower cost, is about building a solution that does just that, and then working with incumbents in the market to fulfill that aspect of the value chain that other people aren't fulfilling.
And here is Saul joining us now. Thank you for that presentation. An interesting concept. How hopeful are you, Saul, that they'll be able to grow this over time?
I feel hopeful. Otherwise I wouldn't get out of bed every morning and keep trying to do it. I think there's a healthcare is becoming increasingly more expensive. It's making less sense from a business side of things, and it's certainly making less sense from a consumer side of things. And there's also a huge impetus from the government to make universal healthcare accessible, not least of which is demonstrated through the National Health Insurance Program that they're exploring. So I feel quite confident that we're moving in the right direction.
I suppose there needs to be a degree of patience there. You know, you mentioned eating an elephant, and it can take a long time to eat an elephant. And even though you might do it one step at a time, you mentioned those early steps, many of which will be building the model around prevention, maybe education about being healthy in the first place. And how would you go about doing that?
First of all, I agree. This is maybe a multi-generational project in our hands to revolutionize a healthcare system and set it up for the future, changing the way incumbents work for the benefit of that. Certainly, you cannot deal with healthcare unless you consider the socioeconomic elements of an individual and a population in delivering that healthcare. I think that we are in the modern age where collection of data is easier and easier, and where turning that data into meaningful analytics is also increasingly easier. So I think collecting that data and making it readily usable and available to clinicians and to planners of healthcare is probably an important step. Look, I think because every consumer of healthcare on the planet will shortly have an intelligent device in their hands, it becomes increasingly easy to monitor them, to push content to them, to use behavioral economics to incentivize them to look after their health. And certainly all the devices they're going to be wearing will feed that data through, like as simple as a watch, for example, like Apple Watch.
Yeah, you mentioned there that there's been an escalation in the uptake of this technology since COVID-19. It's often the way, isn't it? You know, it takes an international, global pandemic tragedy or a war that moves technology on, and not just that, the uptake of that technology. And we're seeing quite positive results, aren't we? I think we were, perhaps the older generation particularly, a little bit cynical about using that device that's in our hand for these purposes. I mean, it's way beyond a telephone these days, isn't it? It's if it can, monitor your health and give you access to those services, then we really need to be investing in that technology and the education program that will come with it to make sure people use it.
Absolutely. It is like the reality with healthcare, irrespective of the fact that this pandemic has accelerated the use of virtual care and telemedicine. Healthcare has always been an incredibly slow industry to adapt to new technologies. And then it makes sense. You're dealing with people's lives. You're going to be more conservative in changing to new things that you may not trust or may not be proven, or there may be complications or unintended consequences that aren't fully understood. And so, I mean, I think I read the other day that when the stethoscope was invented to the time it was commonly used by doctors was almost a century. And that's how slow adoption can sometimes be. We're in a different world where things are adopted a lot quicker. And so, yes, in this situation, it took a pandemic where we didn't want to go into the doctor's rooms to contract a serious illness there that from other patients that had been there, where doctors, for that matter, didn't want their patients coming into the rooms to contract the same illness, to accelerate this adoption. And I think the acceleration of the adoption of this sort of telehealth and virtual care has been for the positive. It makes an additional layer of care available that wasn't there before. There certainly are situations where it's still better to see the patient in person. But this definitely widens the funnel through which people can be funneled into the rest of the healthcare system without having to go seek out physically a nurse or a doctor or some other specialist.
Yeah, I was thinking there of my own parents who, during the pandemic, did suffer some illnesses, weren't able to access the doctor. So we had a presentation prior to yours about local community nursing, people visiting, and making sure that care is delivered, particularly to the elder population, because not just the elderly population don't always understand or take up the technology or even have the smart device in the first places, but often they trust people, don't they? They trust the uniform, they trust the doctor, they feel safe in a hospital or in a doctor's surgery, even though perhaps their youngers are saying to them, yeah, you really don't need to go there and queue up. This is available in your palm of your hand, and they just don't get it, do they?
Well, healthcare's got two components to it. Rationally, you want to feel better. You want to get the appropriate medications, the appropriate procedures, the appropriate advice. But at that same time, you mustn't underestimate the importance of the emotional aspect of healthcare, which needn't have anything to do with actually the treatment to get you better. It can be just that sense of feeling cared for that can make a massive difference. So you can imagine a mother bringing her young child in. The young child is very sick. Yes, the doctor may give the medication and may do the appropriate wound care or provide the appropriate treatment. But if that doctor doesn't allay the mother's fears, despite the fact the child's got what they needed, the mother's not going to feel better. And as a result, probably the child won't feel better either. So one has to consider the fact, we talk about elderly people, it's not just elderly people, it's also young people who want to feel cared for. It's just that younger people are more likely to feel cared for over a piece of technology where a human being's on the other side than people who are less used to using that technology.
Yeah, and I think you're absolutely right, is that sometimes that reassurance, you just want to know when a doctor or a nurse or a medical practitioner says, in my opinion, I've seen this before, it's quite natural and you're going to be okay. I mean, that in itself is worth all the medication in the world, isn't it? So we need to embrace that. Thinking now of the cost and the rising costs. I mean, people chase the money, don't they? That's the problem, is they chase the quick money, the money that they can get straight away for the more expensive procedures, et cetera, which we're trying to stop. And that's what I'm getting from your presentation. And that, but they don't necessarily see the benefits of reducing the illness in the first place, the benefits to the economy, to communities, to society in general. Less poor health means more wealth, doesn't it, in that respect?
Yeah, absolutely. I mean, so I actually slightly disagree with you here. I'm sorry if this point didn't come across well enough in my presentation. I don't really think it's the clinicians' faults. And I don't think that is the health insurers' faults. I think that the system has been set up to create certain incentives for them to behave in a certain way. If an unregulated, listed insurance company is pursuing profits, and it needs to pursue profits because that's what its shareholders want, and the system is not regulated, then they will do what they need to do to make those profits. And that's completely within their rights. That's the way the system has been set up. At the same time, a provider who needs to make a living through delivering services, and they need to deliver more services to be able to make a living or to make a better living, they will continue to do so. And one thing I've realized, by the way, with clinicians is that despite the fact they work in the health system, they don't actually understand the health system within which they work a lot of the time. And so I think what needs to happen is not just asking these parties to the healthcare system to change. I think what needs to happen is there needs to be systemic change, regulated change, and change that, if guided in the right way, will actually make things more profitable and more pleasant for funders and for providers, for the demand side for healthcare and for the suppliers of healthcare and for the funders of healthcare. Everyone can benefit. But in order to coordinate that change, there needs to be a coordination between different parties, a willingness to do so, and there needs to be a degree of incentive to make that change.
Yeah, thanks for explaining that. That does make that perfectly clear. And those incentives, how would they look? What would you see as a good incentive?
At the most basic level, what you want to do is you want to pay healthcare workers to keep people healthy, not to treat them when they're sick. If you treat them when they're sick, then you don't have an incentive to make them get better at a very crude level. Not that I'm saying doctors don't want their patients to get better. Whereas if you pay to keep someone healthy, irrespective of whether they're sick or not, you're going to try and make sure they never come back to your doctor practice, that they never come back to your hospital, that they never come back to your nurse again. And so you can do everything in your power to treat the root cause, or to refer that patient to the appropriate level of the healthcare system where they can get the appropriate level of care, because your objective is to make sure that you can have as many people under your coverage as possible, because you're going to receive a fixed fee per person under that coverage. And if every single person is sick there, you can only see this number of people. But if very few of those people are sick, then you can look after a much bigger pool. And so there it makes sense from an incentive perspective to keep people healthy.
Well, and on that note, Saul, I think you're absolutely right. Who would disagree with that methodology? Let's hope that this elephant eating contest starts straight away and progress is made. I'm using your analogy there, of course, but it's good that we've got people like you on board, spreading the message and bringing that to everybody's attention, particularly during Africa Health Week. You've actually had the closing presentation, and I think that is the perfect way to close it. This idea that, let's prevent, let's keep people healthy in the first place. Let's bring costs down. Let's make things accessible. Let's scale. Let's use the available technology. All of those messages came across loud and clear in your presentation. So I want to thank you and enjoy the rest of your day wherever you are, Saul.
Thanks so much for your time. Glad I closed.
Thank you. That's Saul Kornik there. Thank you so much to Saul and all of our presenters, not just on today, but throughout these 3 days that we've enjoyed at Africa Health Week. The presentations are all available to catch up and view again on the YouTube channel. Future Health YouTube channel is where you'll find them all. We've had some incredible sharing of ideas and knowledge, education, plans, thoughts, and that conversation can carry on. You don't have to leave us now just because the presentations have come to an end. The platform stays open for another 24 hours. You can network and chat. And of course, if you want to take that chat offline, you can take it with the contact details that some of our presenters have shared. Or you can stay online using the hashtag Africa Health Week or Future Health, and just use the hashtag on social media and connect there as well. So there we are. We've had 3 brilliant days. It feels, for me anyway, a very positive 3 days of presentations and discussion and debate. I'm full of hope. I'm sure you are too. It doesn't end there. Of course, if you've attended any of these days, you can pick up your CPD points. They will be credited to you automatically. I mentioned that we are not just in Africa, that we are global. We are going around the globe over the coming months. We've already been in the UK and in the Arabic world. We are going to be in the USA from the 1st to the 3rd of September. So do register for our Health Week series there. Save the date, the 1st to the 3rd of September for USA Health Week, and we'll be going on beyond there to other parts of the world as well. All it remains for me to do is to thank the organisers and Future Health Innovations, all of the partners, sponsors and people who've been involved. Of course, our presenters and the staff that helped put the technology together to bring this to wherever you are. Wow, normally we'd all be in the same room. Let's hope we can be very soon. But the fact that we can bring it to wherever you are in a safe way is incredible. And especially a thank you to you for joining us. Thank you. Thanks for your time. Keep up the great work. And we'll see you all in the USA on the 1st to the 3rd of September. I've been Dave Sharp, your host. It's been an absolute pleasure. For now, take care, stay safe.